Okay, good evening, everyone. We are just almost at 5 o'clock here, so we're going to be getting started. I will introduce myself and I will just keep my eye open to be admitting people into the room. This session is being recorded, so my understanding is that a recording will be sent out to everyone who registered. So thank you for joining us. So my name is Sinead Dufour. I am actually an academic clinician. So I share my time between McMaster University and my academic role. I teach and conduct research in the Faculty of Health Science. And then clinically, I am a pelvic health physiotherapist. And, my main work is at a center called the World of My Baby. Actually, we have multiple centers in Ontario now. I'm a partner in these clinics, and I'm the director of pelvic health, and I run my own practice out of the Burlington location. But I do sort of engage and collaborate with many other different companies and organizations, one of which is the Society of Obstetricians and Gynecologists of Canada. So I sit on a number of their committees. I've authored a number of different clinical practice guidelines that will be a part of what I'm sharing tonight. So I did just want to put that forward. So yes, clinically, a pelvic health physiotherapist. And then of course I have my academic side and a number of other things that I do, but really all in the realm and in the spirit of trying to improve pelvic health for people really across the lifespan. But for the most part, for me, this very much does land in the perinatal care space for women. So today we're going to be talking about, thinking about beyond Kegels to really address, the issues of pelvic floor dysfunction and incontinence really specifically is what we're going to be talking about today. But hopefully getting everyone up to date in terms of what does the evidence actually say and how might we all do a better job of really kind of thinking as upstream as we can where these issues are concerned. All right, so certainly I'm going to review a little bit about sort of the scope and the burden of the problem of urinary incontinence. And for the most part, I really will be coming back to stress incontinence more specifically as related to pelvic floor dysfunction. Stress incontinence, of course, is the most common type of incontinence. And then we'll also spend some time reviewing sort of the effectiveness of care strategies for incontinence, because this is an issue that we actually have really strong data for effectiveness of conservative care strategies. And certainly there is ongoing sort of misunderstanding in the public and even across some different care provider groups of not really having a good grasp of how effective our conservative care solutions actually are. And hopefully, we'll spark some thinking and discussion and some questions going through really to, by the end of this, hopefully integrate, some of this into our practice and be doing a better job at solving this kind of problem that we have. So the problem, right? We're going to go through this. We have a high burden of this problem. What do we know, the evidence and recommendations, and then what are we going to do about it? So that's kind of what we're going to get through today. So the problem, we do have a big problem where approximately, and the prevalence of course does vary across different studies and different forms of data and epidemiological data. But when we net it all out, it's approximately 1 in 3 women across the lifespan have issues with incontinence, right? And so we're talking about a highly prevalent problem across the lifespan, but it definitely pops up in much higher proportions through the perinatal care period, and then again through menopause. And it does disproportionately affect women. That can happen to anyone, right? We have issues with enuresis and leaking with children and nighttime wetting. We have issues with men. So it can affect everyone. It can affect nulliparous women, athletes, etc. But we do see high proportionate amounts of this issue through the perinatal care period and again through menopause. Right, so it's a common problem. And what we do know is that a high proportion of women end up undergoing surgery, either for pelvic organ prolapse or stress urinary incontinence. And, sometimes these surgeries, aren't as effective as we would like. Sometimes these are surgeries that will need to be, done and revised multiple times. And sometimes when an individual has sort of not been given strategies to really empower their body along the way, and they get to the point where, really some of the conservative care strategies are going to be difficult to be effective, they actually aren't a good candidate for surgery at that point in time, right? So again, there's many, many reasons why we need to be thinking upstream and about conservative care options, which of course there are many that are actually effective, and we'll talk about those today. We're also talking about a problem that still remains very much in the closet, that still remains really clouded by a lot of misconceptions. And because of this, we have a huge proportion of undertreatment, actually. And so what we do know, and, it's about 25%, sorry, there should be a percentage sign there. Only about 25% of women seek care. And this is actually very up to date. I sit on the health promotion committee with the International Continence Society, and we have just updated our health seeking chapter of our consultation on urinary incontinence. And so I can tell you, even still, it is only about 25% of women sort of across the globe, when we collate all the data, actually, seek care and seek help for this issue. And, this is, multifaceted in terms of why, but one of the big reasons is because many individuals do have misconceptions about urinary leakage. They think that, just because they've, birthed babies vaginally, that what else should they expect, right? They think that this is something normal and expected as we age. They think that conservative care strategies, like very, sophisticated individualized pelvic floor muscle training, isn't effective, and the only real solutions come in the form of medication or surgery. So again, lots of misconceptions that actually sort of turn people away from seeking care that could help them, right? And even though we're not talking about a life or death issue, we're talking about a pervasive problem that has far-reaching impacts, right? In terms of quality of life, it's huge. Women start leaking, one of the first things they stop doing is engaging in exercise the way they once did, right? And that, of course, is going to have a domino effect from a negative perspective in every single biological system. And then from there, we can even have some retreating in other things that socially they would want to engage in and fulfilling certain social roles, and starting to retreat in those, starting to retreat in forms of intimacy, and so on and so on. So we have major sort of snowballing of negative effects with this issue. And really, when we can kind of nip it in the bud right away or prevent it upstream in the first place, it can be very, very straightforward to correct. So it really is quite tragic, the proportions of people we have sort of suffering the way they do. And really, all of us have a role to hopefully change that. So just to kind of build on that, in terms of, why people don't seek help, I mean, some of it too does have to do with, normalizing even from messages in the media, but also from sort of messages people have heard from very well-meaning care providers, but misguided care providers who are maybe kind of giving them information that some of these strategies don't work, or that these issues are to be expected. And, there is a degree of just sort of dealing with it that has to go on, and just kind of wear a pad and kind of carry on. And so it's really important that, all of us are very up to date from this perspective. So we're all being part of the solution. As I indicated at the beginning, there's different forms of incontinence, right? We have stress incontinence, which of course more has to do with the mechanism of the pelvic floor, which I'll talk about more in a minute. We have overactive bladder symptoms, which then can merge into sort of urge incontinence. And this has more to do with the bladder muscle, the detrusor, that's the muscle that's embedded within the bladder. And we, of course, can have a mixed picture in others, but we do see that stress incontinence, this mechanism of the pelvic floor, is the most common type of incontinence, right? And so again, we have, major sort of bottlenecks in our healthcare system when it comes to incontinence. I'm really sort of fortunate that I collaborate with different healthcare practitioners sort of through the Halton area and through my role at McMaster. And so it's something I'm talking about a lot with primary healthcare providers, with specialists, with urogynecologists. Dr. Carolyn Best is just down the road from us here. I'm speaking to you from Corelife Wellness. And this is something even her and I talk about a lot. Her wait list is massive. And really, it's not appropriate or indicated or evidence-based for her to be doing medicalized treatment or surgery on people when actually conservative care is what they need. And so she's then constantly kind of, sending these people back for conservative care after they've sat on a wait list to see her for, a year and a half. And so it just goes to show that all of us need to do better at every different sort of level of the healthcare system, and there are some barriers in the way. And one of which, though, is knowledge and awareness in the public in terms of what strategies actually work well and where you can get those strategies. And then, that same knowledge for every different relevant provider group who's interfacing with these women. And then, of course, there's also a lack of emphasis on prevention. And there's more of an acceptance in the healthcare system of really just kind of waiting until the issue gets much more severe before trying to provide a solution. And what we actually see is that our conservative care strategies are incredibly effective to the level of cure when the issue isn't as severe. The more severe the incontinence is, it usually means the more conservative care strategies we need to apply. So we really do want to be thinking upstream, right? And not leaving it. So these are just kind of the common misconceptions, sort of FAQs, to just really crystallize some of the things that I've said. And these are sort of quotes that I hear from clients all the time, right? I vaginally birthed 3 children. What can I expect? I've already done my Kegels and they don't work. My doctor said just to wait until it gets bad and then I'll be referred to a specialist for surgery. Why did I have to wait a year and a half to hear that I don't have to have surgery? How many clients do I see back in my clinic who are so frustrated having these issues, waiting on a list for a urogynecologist, only to have them turn around and say, no, like you need to actually rehabilitate this with conservative care, and that probably should have been started properly at the primary care level 2 years ago, right? That's extraordinarily frustrating for people. My mom had these issues, so I knew it was coming, right? This automatic thinking, that sort of genetic predisposition really has the majority of sort of what dictates what our health outcomes are going to be. And we actually know in almost all cases that sure, there's some relevance to genetic predisposition, but we know for the most part, it's epigenetics, right? That actually really drive outcomes. And so people really truly need to be empowered to understand this. And so they can recognize that, they truly have the power to make some major sort of changes in how their biology and structure is functioning. And then I am in menopause, and this is what happens. It's all downhill from here. These are some common perceptions, very common perceptions and beliefs, certainly for me that I'm up against when I first kind of interface with someone. And really, it's a matter of me helping to inspire them and empower them and really understand how effective some straightforward solutions are. So what do we know so far? Well, we certainly know that the pelvic floor is a really, really important group of muscles. I mean, there's no other group of muscles quite like this unique group of muscles. The pelvic floor has 5 distinct functions. The pelvic floor actually makes up some of the sphincters. The pelvic floor has a role in sexual function, has a role in visceral support of our pelvic organs, has an important sub-pump function, and has an important role even in terms of optimizing lumbopelvic motor control and helping to manage intra-abdominal pressure, right? So lots of really unique functions of this sort of structure. And so, I mean, it stands to reason that if this important group of muscles gets injured or takes a hit, I mean, we're probably going to have some dysfunction. So, it stands to reason that we need to be thinking about sort of restoring the fitness and function and rehabilitating the structure if it's being injured, right? So that's something important that we kind of need to think about. We also need to understand that the pelvic floor doesn't work in a vacuum, in isolation, right? It works as part of an integrated system. And this is where the whole concept of just do your Kegels is very, very flawed, right? Because as much as Dr. Arnold Kegel was very, very ahead of his time in the late 40s, understanding that this sort of group of muscles, we really should be rehabilitating it like every other muscle group, and absolutely. But the assumption was that the problem is always related to weakness, and we know that's actually not the case. And there also wasn't sort of an understanding of how the pelvic floor actually coordinates with the breathing diaphragm and some of the other lumbopelvic control muscles and the intra-abdominal pressure piece. And so now we're starting to really see how important that side of it is. And it sort of makes sense then why just really focusing on strengthening based exercises just of the pelvic floor with no attention to synergy of the whole system, why that doesn't work well for everyone, right? So we need to really understand that, when we have a good relationship between the diaphragm and the pelvic floor, which is a relationship when we are up tall with a neutral spine, right? In that situation, as we automatically breathe and we inhale into our diaphragm, that sort of eccentric movement of our diaphragm buddies up very nicely with lengthening eccentric movement of the pelvic floor. And then when we exhale and we get kind of this concentric movement of the diaphragm, it kind of comes in together and up. We get the same reciprocal action of the pelvic floor. The pelvic floor comes in and up. So we get this gentle pumping and moving of the pelvic floor and conditioning of that muscular structure when we have the right relationship actually with our diaphragm and when we're actually breathing properly and sitting up tall and standing, right? So even that explains why some of the strategies, even in terms of breath work and just walking protocols, are actual evidence-based treatments for incontinence, because that's actually going to set your pelvic floor up for better function. We often see quite predictably as people are sitting more, they're not engaging in a lot of sort of walking or exercise or upright activity, that correlates with increased incidence of urinary incontinence. So some of these other pieces. We do know that when we're standing, partly we think because of the relationship of structures, but partly because of the impact of gravity, that we automatically have a higher tone in that pelvic floor, right? So again, sitting is problematic for so many reasons. It's inflammatory. If we're sitting too much, we're not going to have that right relationship with our diaphragm. But sitting also isn't going to allow for that optimal tonic activity through many of our muscles, including our pelvic floor, right? So just another reason why we have to watch how much we're sitting, right? That being said, I mean, we know that there are a whole bunch of interrelated risk factors, and it's not to say, to allude to the point I made before, that genetics don't have anything to do with maybe predisposing an individual, but it certainly isn't the most important piece when it comes to incontinence. And there are lots and lots of things we can do to, on the offensive side, to really, really build up optimal sort of capacity, fitness, and function. And then on the defensive side, to understand what are going to be the things that are going to be potentially sort of mitigating optimal function of the pelvic floor. What are some birth practices that are known to be problematic that we can actually potentially avoid? What are some other behaviors that are known to be problematic that we can avoid, like persistently straining on the toilet every time you're having a bowel movement, or lots of persistent breath holding behaviors, etc. So it's a matter of really understanding all the different risk factors, but understanding that a lot of what we actually do have some control over, right? So there is lots of different ways that we can end up with some trauma to the pelvic floor. I indicated earlier that we see higher proportions of pelvic floor with sort of high impact athlete populations. We see higher proportions of pelvic floor injury through birth, particularly if there were certain obstetric interventions, right, that correlate with more trauma. And certainly we know that persistent chronic coughing, when we think of the recurrent strain and increases in intra-abdominal pressure, and then straining on the toilet and constipation. These are all established risk factors that all are going to kind of damage and strain the pelvic floor in different ways, right? That having been said, these are all sort of issues that we can overcome. And really, people need to be empowered to understand how to overcome these issues, right? We had sort of traditionally always thought of stress urinary incontinence as a weakness problem, right? This has to do with a weakened pelvic floor. And so our solution always has to be around strengthening the pelvic floor. And actually, the more we've learned, the more we've sort of understood that that isn't quite right. In some cases, yes, it seems to be mostly a strength problem. But really, when it comes to stress incontinence, it's the whole sphincteric mechanism just isn't working well. And sometimes it's not working well because it's truly weak. Sometimes it's not working well because maybe it's presenting as weak, but actually there's just way too much tension in the whole system. And the pelvic floor cannot respond and the sphincters can't close and lift, in a timely enough fashion. They're not responsive enough, right? So we certainly know that, the urethra doesn't have the sort of stability that it needs, but it doesn't necessarily mean it's a strength deficit that's causing that, right? And we certainly know that the sphincter isn't closing and lifting, right, and well enough in response to intra-abdominal pressure, right? So we know there's some decreased capacity there. But again, it's not necessarily a strength problem. And this is why it's really, really important that before we start sort of, determining which menu of options of care strategies might be best suited to someone, we really have to do a proper assessment first, right? And that's really, really important. So we can kind of be tailoring that, and then we're much more likely for that to be effective. So many of these options are from the most recent Society of Obstetricians and Gynecologists of Canada clinical practice guideline on conservative care. Myself and Dr. Maria Wu, who is a urogynecologist that practices in London, Ontario, were the lead authors on this. But of course, all the clinical practice guidelines get vetted through the entire urogynecology committee. And so what kind of teased out through this guideline, as well as another one that is in press at the moment, is sort of level 1 and level 2 options for conservative care for urinary incontinence. And so our level 1 options, we have very, very strong evidence for these, right? So for different behavioral modification. So I've mentioned a few times around intra-abdominal pressure management, constipation, straining on the toilet, holding your breath, etc. Lifestyle changes. So there is some data around increased weight and BMI. We think kind of from a pressure perspective. We also think from a inflammatory mechanism perspective. And then we have some data even in terms of fiber intake for bowel health and fluid intake, pelvic floor muscle training. So again, this is the appropriate terminology we should be using when we're talking about any type of exercises for the pelvic floor. The guidelines really do stress that the term Kegels really should no longer be used. Kegels are based on an assumption that always our goal is to strengthen, and because that used to be the assumption. And since we know that's not always the case, it has been acknowledged by the SOGC and the International Continence Society that really we should just no longer use the term Kegels because it's actually confusing and it's misleading. And instead, we should always use the term pelvic floor muscle training, knowing that for each individual person, what they are training is going to be unique and based on their individual needs that are determined on an assessment, right? And then, of course, other behavioral modifications. In the case, for example, of urgent continence or overactive bladder, This is when it becomes more important too to make sure that individuals have appropriate bladder habits, that, people are not peeing just in case. And, they are not rushing when they're peeing. They're not hovering over toilets. They're really engaging in healthy, proper voiding habits. Many women are very surprised to learn that what started off as a stress urinary incontinence and then also has now turned into some overactive bladder symptoms as well, that they themselves very likely caused that issue through their own coping behaviors around their stress incontinence. Their bladder control isn't as good, so they start kind of trying to just keep their bladder as empty as possible and engaging in what we call defensive voiding. Well, that, of course, really goes against the neurobiology of how our detrusor muscle works. It's only meant to sort of contract and empty when it's actually full. And so we need to then help people understand how to retrain their bladders after. We also need to clue people in once bladders get really hyperactive. They don't have the same tolerance that they did before, right? So the alarm bells go off a lot easier. So just like the alarm bells will go off when there's only a little bit of urine in the bladder saying, I need to empty, also the bladder will get irritated more easily with certain compounds, right? We refer to these as bladder irritants, and there's a whole list of things, and some things are more pertinent to some individuals. So again, this is where sort of our detailed assessment and history have to come in. And then when it comes to our level 2 interventions, which are still very worthwhile interventions, and these are important interventions to have available as a full menu of options for people. But this is when we get into using our intravaginal continence devices, our external supports, some of our e-health or M-health solutions, and I'll kind of go through those in a moment, and then some of our other more novel, higher tech technologies that I'll spend some time talking to you about through the presentation, right? So again, we have really, really good data for these tools, and we certainly do not want to be using the term Kegels when really what we're talking about is pelvic floor muscle training. So that's important. It's also important to understand that, and COVID certainly taught us that while it is gold standard and optimal to be able to have someone in person and assess them and actually assess their pelvic floor, right, through a vaginal or rectal exam, that is optimal, that's gold standard. But that isn't necessary to still have good guided care. There's a lot of other ways that we can kind of assess through different virtual means and through really good history and through sort of tracking in some psychometrically sound questionnaires. The other thing that's exciting about some of the technologies I'm going to talk about is through the use of the technologies, we can actually get a form of sort of feedback into the system and proprioception into the system that can kind of also help the brain connect a little bit better with the pelvic floor in the absence of any sort of internal palpation proprioception. So when we are, though, doing a pelvic floor exam and we are really trying to tailor sort of a pelvic floor exercise protocol to exactly the deficits of that person in front of us, we, of course, want to get a sense of power that we grade on the Oxford scale. We want to get a sense of endurance. We want to know, well, can we do some endurance testing and can we kind of repeat that over time? Or do we see a fatiguing out effect? Is the pelvic floor responsive, right? Is the individual able to get good activity, good lift, good closure when they're doing it slowly, when they're coordinating the movement with their diaphragm? But when we ask them to contract and relax their pelvic floor really, really quick, we notice that is kind of where they have a stumbling block. And then that's, of course, where we would then want to direct treatment, right? And then it's also important that we have a sense of, are the automated functions of the pelvic floor in place? When an individual coughs and there's that rise in intra-abdominal pressure, what should happen is the pelvic floor should automatically contract, close, lift in preparation of, the visceral structures coming down in response to that pressure, right? In an intact functioning system with good capacity, that should all happen automatically. But when the system isn't functioning well, or some of those reflexes have been damaged, or the pelvic floor just doesn't have the capacity it once did, then that's not going to happen. And so it's important that we're also checking, is that automaticity there? When the pelvic floor contracts, we should also have some automatic coordination with the transversus abdominis muscle, which is one of our other deep inner unit lumbopelvic control muscles. Is that happening, right? We need to be checking kind of for all of these things. And we also have to get a gauge on, when someone does cough, is there a lot of excessive mobility of some of the visceral structures coming down? And if there is, that's when we need to go on and do a more detailed prolapse check. We also want to check in the pelvic floor too, the degree of protection and upregulation that's in the pelvic floor. The pelvic floor, of course, is unique in that it is very connected with our stress response system and our threat response system. So one of the things we will find is those individuals who don't have that system in a good homeostatic state, will have a lot of tension through different chains of muscles that correlate with that system. And the pelvic floor is one of them. And, we can flag this pretty easily when we touch, and we do basic light touch. And that is felt as being quite tender on the individual. And that, of course, is allodynia. But again, if we are not able to assess this person in person, right? Because certainly I know in my practice, a lot of it is virtual care still. We can actually use the central sensitization inventory, the CSI. And we know quite clearly that tenderness in the pelvic floor, this upregulation in the pelvic floor, correlates with a score of 40 or over on central sensitization. And when people's tissues are sensitized and they're in a very wound state, this is not the time to be focusing on fitness of any of their structures, let alone the pelvic floor. This is when, sort of through our rehab lens, we need to focus on getting the sensitivity down in their tissues. So, as a physiotherapist, I'll then shift my focus to the autonomic nervous system and sort of the neuroinflammation that's there, get the system wound down, less sensitive, before I'm moving on to reestablish fitness capacity of the pelvic floor, for example. So these are all the things that we need to be checking, but varying degrees of these we can adapt if we aren't able to see someone in person. When we're initiating pelvic floor muscle training, in a perfect world, we're going to initiate it based on exactly what all the assessment parameters were. But if we haven't assessed someone in person and we don't have that information, one of the safest places to start is, at the very least, helping an individual to understand how the pelvic floor partners with all those other structures I already said, helping an individual to understand that, the relationship between their diaphragm and their pelvic floor is really important. So sitting up tall with that nice neutral spine and really getting a sense of, as they inhale and they're getting some nice lateral movement in their diaphragm, trying to sense sort of the lengthening in their pelvic floor, that opening up between their two sitting bones, and then thinking about connecting their pelvic floor as they exhale. So they're really sort of working with their body's own organic physiology. And many individuals actually are in a habit of not breathing well and bracing. And they very much feel that they almost want to try to contract their pelvic floor as they inhale and suck in. So even just right there, it gives us lots of opportunity to correct kind of some bad habits that really aren't serving that individual very well. Individuals who have a hard time sort of connecting with their pelvic floor with some of the standard cues that we might say in terms of, imagine like you are gently sort of lifting a tampon back into place. It's slipping out and you have to correct the position of it without using your hands, for example. There's a lot of data that shows that, because the sphincters of the pelvic floor and right around the rectum are much more robust, that rectal cues tend to work a lot better. So one of the best cues that's cited in the evidence is actually imagining like there is a small, smooth marble just in the rectum. And as you exhale, you're gently using your rectal sphincter to gently lift that marble up. And as you inhale, you let it go again. So really, if you're not sure exactly where to start, this is your best bet, because at least you are going to be making sure you are getting the brain to find the pelvic floor, you're getting your pelvic floor connecting properly with the diaphragm, you're taking care of the positioning and setup piece, and you're not sort of running the mistake of focusing on using terminology like just squeezing your pelvic floor, and you're really focusing on lifting. And then you're also emphasizing that the relaxation and the letting go is just as important as the lifting. So we're getting the concentric and the eccentric piece. So you're kind of covering a lot of your bases. So I, teach a module to the family medicine residents at McMaster, and this is how I teach them to initiate their pelvic floor muscle training. If they're kind of not sure where to start, there are so many people that can be helped simply just by doing this, and then helping people to understand how to then take this and integrate it into their everyday life. Right? Because really, the pelvic floor is integrated into the rest of everything we do. So as people start to understand, okay, it's as I exhale, that's when the pelvic floor is going to come on. Well, really in your tasks, you should be exhaling through tasks that require effort. If you don't, you're going to be likely to breath hold through those tasks, right? And breath holding is not really the best strategy if you're having some issues with bladder control, right? So we want to get people in a habit of exhaling through tasks that require effort, and exhaling and contracting their pelvic floor through these tasks. So that can become, when they go from sitting to standing, right? It's almost like mimicking a squat. When they're lifting their groceries up, what they can get in a habit of integrating these. And then if the care becomes more nuanced than that, that is when it is really, really helpful to refer out to a pelvic health physiotherapist. A lot of these basic strategies out of the gate really need to be sort of executed across the board by midwives, OBGYNs, nurse practitioners, family docs, all relevant healthcare providers, really. And then when it becomes more nuanced, that's of course when it's really good to refer on to a rehab sort of specialist like a physio. This is just a slide to highlight again how important the posture and alignment is. There are many, many clients that come in to see me and say they were told to do Kegels, contract as hard as they can and hold it for 10 seconds with no regard of any other component of what the tissue is doing. So even that right there is not sound evidence-based advice. But then they're actually told to do it while they're driving and while they're sitting in the car. And when you're sitting in a car, it's very, very difficult to be sitting on your sit bones with the correct alignment. It's also really difficult to be tuning in and really paying attention proprioceptively to what's happening in your body when you're trying to drive. So definitely we don't want to be giving out advice, like this. Some of these pieces I've talked about are really, really, really important. So I mentioned about the sort of level 1 strategies. Obviously, pelvic floor muscle training is one, but so is kind of general exercise training. So low impact exercise and walking is an excellent level 1 treatment for incontinence. We don't want to forget about that. We also want to make sure that we are thinking about other strategies that might be important to actually get people moving and active again. And this is why I really love the intravaginal devices, because they're really great for people, especially while they're exercising. And so certainly any of our level 2 options, we wouldn't want to be doing those without our level 1 options. But for many individuals, when we can layer in some of the level 2 options, this is when we actually get some sort of life-changing outcomes for these folks. So let's just talk briefly about what a few of those are. So intravaginal continence devices, as I said, these are level 1 options, really good evidence to support these tools. So the Uresta is more of a permanent silicone-based intravaginal tool. It goes in, it kind of slightly kinks off and supports the urethra. So it provides a little bit more sort of stability there, and actually serves as a bit of a support tool that's going to prevent too much downward motion of the visceral structures actually while you're exercising. So you can kind of get a bit of organ support there. And then Emcela, which is a product by Poise, is the same idea, but it's disposable. So it inserts like a tampon and then it's disposable. So these can be really great tools for those folks who are saying, yeah, like I had to even stop with like my hikes and my walks with my girlfriends, or we used to kind of walk the stairs and I can't do it because like I'm leaking the whole time. And if while we are trying to get the capacity of the pelvic floor better and conditioned, but in the meantime, we need something kind of a supportive tool in the meantime to actually get them exercising, these can be great tools. These are other tools, external supports, because not every person is particularly interested in an intravaginal tool for a whole variety of reasons. These tools definitely have less robust data. So these would be, I would even consider the external supports, not even level 2. I'd probably consider them level 3, but they certainly do have some data, which is exciting. And anecdotally, really, really good feedback from these tools. So SRC Health has a product that they just launched actually about 2 years ago called their Restore Shorts. They have a piece of patented technology kind of in the perineum area. And, you know, they think the mechanism of why these shorts seem to help with incontinence and prolapse is because that technology is meant to put some proprioceptive input into the pelvic floor, right? And I have to say, you know, because they have some, you know, research that they've done, and certainly through COVID when I wasn't able to see people as much, I would suggest these shorts as an option quite a bit, and really, really good sort of feedback on this being a lovely adjunctive tool. A similar product that a colleague of mine, Dr. Donna Fedorico, urogynecologist from McMaster University, actually ran a study on and showed good outcomes, is called Hideaway. And so again, this is for incontinence and prolapse symptoms. Both of these are for incontinence and prolapse symptoms. And really, I think probably works with a similar type of a mechanism. But those are certainly options for people if they want another supportive tool. And I believe these types of options are really, really underused. This is just actually a testimonial, and there's a number of them actually on the Hideaway website, a number of testimonials. And oftentimes I get the same type of feedback back from my clients. And really it's just in the flavor of individuals being frustrated because their physicians or conventional sort of care practitioners basically told them that there are no other options for them. And sure enough, they go online themselves, they find Hideaway, and it ends up being a game changer for them, right? So we really do have a responsibility to be aware of a whole different menu of options for people, and then they can kind of make their own choices in terms of what will be best for them. As far as some other sort of e-health or M-health solutions, this is actually a clinical practice guideline from the SOGC that is in press at the moment. So this is just pulling off our draft. This is not published. It will probably be published in the next month or two. But really, it's acknowledging that, you know, we have a huge growing space for e-health and M-health interventions for incontinence. And actually, we have some good data when they are offered in conjunction with some of the other tools, that we see the data across the board shows that there is some value to doing that. We certainly see that the tools, and in particular, there's one app that was studied quite a bit with excellent outcomes that I'm going to talk about more in a minute, that was very much based on clear self-management support principles, actually showed to have really good efficacy, right? So we need to be aware of these tools as well to further support our clients. So more of the benefit of these types of tools really were around stress incontinence actually than urge incontinence. You'll see here that this is the app that has been studied quite a bit. It's called the TAT app, and it was developed in Europe. And, you know, basically there's information in this app about the pelvic floor, about stress incontinence, about lifestyle factors, all of those pieces. There is kind of ways to sort of track the different exercises you're doing. And then there's a whole section explaining about different components of pelvic floor muscle training, right? And the different aspects, and trying the best to help people to understand which ones might be most relevant for them based on their symptoms. So again, there's some really good data for effectiveness of using an app like this based on these principles. And then the other image there, you'll see it's this one is LV, but there's a number like this on the market. So like PeriFit's on the market, we have LV, and we have other sort of, they're called Kegel trainers on the market. And essentially this is an intravaginal device, but it's connected to your phone by via Bluetooth. And, certainly there is, a way to get a little bit of sort of feedback from the tool to give you a sense if you are contracting your pelvic floor properly, like in the right direction with the sensors that are in there. There are different sort of programs and games that can go along with it to sort of motivate people to sort of carry out like a decent amount of time of doing some pelvic floor exercises, that could actually have a treatment effect. And again, we see some reasonable data that this can be useful, right? If this can be kind of motivating for people, it can be useful. So it has a place, as long as it is not used instead of the other solutions. And then this is a newer and a pretty exciting technology. And of course, where I am coming from to you today, I'm at Corelife Wellness. And, at the womb, we're really delighted that we get to collaborate with Corelife Wellness, because Corelife Wellness actually has this tool, and really the full spectrum of all of the tools that I've talked about, but does have this tool. So this is a piece of technology called Emcela, and it's manufactured by a company called BTL. And really it uses something called high FEM technology, high intensity focused electromagnetic stimulation. And I actually am at a room here at Corelife, and it is right behind me. So that is it right there. And essentially, this is sort of like a newer, more advanced form of electrical muscle stim. So traditionally, when we needed stimulation to get the pelvic floor going, we would actually have to use internal probes on these kind of old clunky machines. And individuals would kind of have to come into the clinic to have this done, and it's an intravaginal strategy. And we have some good data that, when we're having trouble getting the pelvic floor going, that EMS can be a nice additional tool. Well, this technology, as I said, it's higher intensity and it's a little bit more focused. And there have been some really great studies on it. That having been said, since it first came out, there is an element of, well, it almost seems too good to be true, because you're sitting on this tool fully clothed. And after only 6 treatment interventions across 3 weeks, reports of these fantastic outcomes. So, I myself as a researcher, when this tool just first came out, I wanted to really do my own due diligence and just scope all of the literature. And so our systematic scoping review is still in progress. And really it was to look at what is the efficacy of all types of EMS. So we could kind of compare different forms of it, our more traditional forms to our newer forms, and the types of EMS that go intravaginally versus extravaginally. But our interim analysis has actually really shown so far, and we're doing an ongoing, more detailed analysis, that, EMS across the board definitely is helpful, but definitely there is a trend towards this high intensity focused electrical muscle stim being even more helpful. And certainly, anecdotally, I can say, just from having an opportunity to collaborate, is really fantastic outcomes. So it's just great to have yet another additional tool, to be able to use. And then again, we want to be thinking, yes, of treatment, but also on prevention. And I've mentioned these already, but I'm going to mention them again as we're wrapping towards the end, in terms of lifestyle and behavioral factors. So constipation is a huge risk factor for pelvic floor dysfunction and urinary incontinence, period. So this needs to be addressed. It is going to do no one any good to have any sort of mixture of these different types of technologies and the most advanced prescribed pelvic floor muscle training protocol based on an exquisite assessment if they are continuing on with constipation that's not addressed, right? It's not going to work. Same thing goes with just chronic straining behaviors and chronic coughing. So again, if someone's immune system is so compromised that they are constantly sick and coughing, I mean, we need to really drill down and address that and really empower their immune system, because simply put, the pelvic floor cannot manage that. We're not meant to be sick and coughing all the time, right? And then, of course, we know that there are a number of obstetric factors that really predictably are problematic for the pelvic floor, right? And that in ways is almost a whole entire conversation in and of itself. But there certainly is lots that needs to be done and improved from a prevention perspective when it comes to sort of perinatal care and obstetrics, right? Preventing issues in the first place, but also then very quickly and, in a very sort of automatic and routine way, soon as women have birthed those babies, all of us who interface with these women should always be going through a very detailed check of kind of what's happening with these structures and making sure people know all of the different things available to them to promote more optimal pelvic health or to restore optimal pelvic health. One thing I did want to say in the spirit of newer technology, because of course, we're really excited about Emcela as an additional fantastic tool, but another newer technology that's been out that is oftentimes indicated as a tool for incontinence, I just need to say a bit of a consumer beware or a healthcare practitioner beware. And this is vaginal laser. Intravaginal laser, which, yes, there is good data to indicate that this can be helpful for certain symptoms of menopause, urogynecological symptoms of menopause, mainly dryness. But oftentimes this is touted as a solution for urinary incontinence. And even as of the most recent synthesis of all of the data and all of the studies, and there have actually been many looking at incontinence as an outcome. So I'm pulling this actually from the International Continence Society Symposium that just ran this past year. We don't have data confirming that this is useful for incontinence, right? Also, the review that we did at the SOGC in 2018 indicated that, we have too much heterogeneity across studies. We don't have enough long-term data to even show safety. And so, certainly this is not a tool that, as far as the ICS is concerned or the SOGC is concerned, should be recommended for urinary incontinence, right? So we want to embrace the technologies that we have some data for, but we also want to make sure we're not connecting up with the technologies that are not appropriate for that, right? So just as we're kind of wrapping up towards the end, and then we'll have a chance for questions, Brittany is here with me from Corelife Wellness, and she'll be kind of moderating the questions in the chat. But it's to acknowledge that absolutely out of the gate, the most effective tool is, of course, pelvic floor muscle training, right? So this really needs to be a part of everyone's care plan, and some type of a proper assessment needs to be done. We do have thorough ways that we can do this, even if we're not in person. And I guess where, we want to kind of be creative is around how we can kind of get feedback to that individual when we're not seeing them in person. So either sort of feedback with themselves palpating on different structures and we're guiding them in terms of what they should feel, or if in addition to, us talking them through some of those basic initiation of pelvic floor muscle training, coordinating with the breath, maybe they are going to seek out an adjunctive tool like the LV or like, the Emcela chair here. And those tools themselves can kind of provide some nice proprioceptive input, and some feedback into the system that can really, really help. It's really important that people understand why the exercises they are doing are actually helping them. And they're not having a disconnect in terms of understanding, well, How is this actually going to assist my problem? And that's been another miss sometimes when it comes to prescribing pelvic floor muscle training. There hasn't been enough time sort of explaining why these are helpful and the different things. It's one of the reasons why we think the TAT app works so well, because not only are self-management support, behavioral health coaching principles used throughout that app, but there really is a lot of kind of education there, right? Lifestyle factors beyond exercise are key. So exercise is key, but we also need really good sleep so that the tissue is actually fit and responsive and can function. We also need to make sure people, have reasonable weight management, that they're having optimal fluid intake, right? That their nutrition is good, their microbiome is good. We talked about constipation already. So really kind of whole health status is important. And it's also important when we talk about just immune system because of the coughing issue that we mentioned before. And then again, I mentioned already about the perinatal care period being a really important kind of time that I think we're still missing a little bit in today's day and age. And certainly the research would also say that we need a little bit more time to at the very least start this conversation. So individuals are not going through their life normalizing these issues that are not normal and that usually are very straightforward to solve, particularly if we catch them early, right? So that's really important. So we have lots of barriers from education, and of course I work in that system trying to improve it there, to just difficulties implementing these best practice guidelines. We have all these fantastic guidelines at the SOGC, but not a lot of effort goes into actually implementing them. So I mean, there's lots of barriers for sure. But they are all barriers that I believe that we can overcome and that we need to overcome. And certainly awareness raising is the first step. And that is what we are here for today. And I really am grateful for Corelife Wellness for hosting this actually as really as an effort to serve the public to try to raise awareness on that issue. So that is all I had. Thank you.